Well, good morning, everybody, and it's very nice to be here again this year. So what I'm going to do is to just reflect on probably the National Cancer Survivorship Initiative 2008-2012, to think about what happened in the 3 years in between, and then perhaps think about some of the opportunities and challenges which are faced with us now, with a new cancer plan about to be launched, but in a very different scenario from the one that we were in when we started. So I think it's just thinking about some of that learning. And then I'm going to finish off just by reflecting on the experience in Northern Ireland in implementing survivorship and perhaps some of the learning that that might have brought. So if we think about what did we learn, what have we learned so far over the last few years? Well, I think we were able to test various different models of care, different ways of doing things, and demonstrate that it was possible to do things differently in relation to changing aftercare, in relation to return to work, in relation to consequences of treatment. So we've demonstrated that it's possible to do things differently if the circumstances are right. We've learnt that in terms of patient experience, the most important thing appears to be having access to a clinical nurse specialist. And that does seem to be a very important thing, but we've also learnt that it's not possible for that clinical nurse specialist to be able to cover everything that the patient needs within the community, within the non-health needs, and that there's a need for people to have different relationships with each other. We've learnt that people's quality of life after cancer treatment is not just related to their cancer, it's also related to the impact of the treatment, and it's also related to the other things that are going on in their lives, both in terms of comorbidity, other health issues, and in terms of social and psychological factors, and that these have to be taken into account, and cancer specialists can no longer live in the cancer bubble. The cancer bubble has been well and truly punctured. And we've learned how difficult it is to actually find the data, the numbers that we need to support us in this process because we don't measure the right things. So we've learned a lot of things over the last few years in how to deal with the 4 million people who in 2030 are going to be living with and beyond cancer. And we have to now move to a more, as it were, complicated way of thinking things. It's not enough just to know it's possible to test something. We've got to know, is it possible to actually make it happen on the ground? And in Sheffield, you've been jolly good at that. So some of the highlights, I think, of the 2012 process was that it was possible to demonstrate that you could produce cost-effective new ways of working. And we had developed some implementation plans. I think the consequences of treatment, which has been something that patients have been telling us was something that was really important, but emerged. And we began to produce some literature reviews and some evidence as to how things could happen, and some of those are available today. We also learned that one of the most important things that we have to really focus on is when people, the transitions, that when people move from being a well person to being diagnosed with cancer, when people come out of that protected area where they're having anti-cancer treatment back into the real world, when they develop recurrent cancer and have progressive illness, when they move from the point where their recurrent cancer moves into dying, that these transition points are the points where things go wrong for people. And we've learned the importance of focusing on those transition points in terms of trying to make things better. We've also learned that although we don't have data, always have data, that if we use the data that we have in a more intelligent way, it is possible to be able to count the number of people who have different sorts of problems at different sorts of points. So just using the incidence and mortality data, you are able to get a picture of your population if you just make certain basic assumptions. So if you say that the year after anti-cancer treatment is your treatment phase, and you know there's 4,400 patients who start off with breast cancer, and you know that there's 4,000 people who will live a year, you know that you ought to be getting 4,000 treatment summaries, 4,000 assessments, 4,000 people through health and well-being clinics. You know what your denominator is. And you can, just using this sort of data, get a picture of what you need in your population. And the challenge, oh, we can't do this because we haven't got the data, can now be pushed back. I think we also have learnt an awful lot about consequences of treatment and the fact that, for example, general practitioners don't even code whether you've had radiotherapy or chemotherapy on the whole. So it's almost impossible for them to pick out the people who may have consequences of treatment later. So we've learnt some very important things. However, we've also learned by just using national quality of life data, we can estimate the number of people who have different sorts of problems. So here's something where we took the national survey of patient-reported outcome measures, and we applied that data to the national incidence and mortality figures, and then we could make an estimate in any population of how many people had bowel problems, how many people had urine problems, how many people had sex problems. So I think that that's a very important piece of learning, that there is data there, we just have to use it more intelligently. And using that data more intelligently makes it more likely that we're able to take some of our survivorship programs forward. I think that one of the challenges that we've recognised during this whole survivorship period is how different cancers are and how siloed we've become. So a lung cancer doctor sees cancer as in the way of what lung cancer looks like, and a breast cancer doctor sees it as breast cancer, and they don't realise that they're entirely different illnesses. So thinking about cancer in terms of different illness trajectories has also become very important, and I won't emphasise this one too much, but I think that this will become an important factor, thinking of different illness trajectories. Finally, I think over the last 3 years, since when we first did the National Cancer Survivorship Initiative, it was very much about cancer, cancer, cancer. Over the last 3 years, the policy within this country has been much more away from disease-specific illness and towards thinking about multimorbidities. So we as a cancer community can no longer see ourselves separate as a cancer community. We've got to see cancer in the context of other illnesses and cancer in the context of other health and social care needs. And that actually reflecting on the fact that most cancer patients are going to have at least one other illness. And as things go on, they will have more illnesses, and our cancer treatment will have an impact on those illnesses. So now we have to think about how do we engage with care of the elderly teams? How do we engage with general practitioners? How do we engage with different people so that patients don't have to go and see 6 different specialists? That specialist expertise can be brought in to whoever actually sees the patient. So that's a big challenge. That's a different way of working. And it's something, again, which has emerged over the last 3 years as we've moved from the cancer bubble to a policy situation where policy now doesn't want to think about disease-specific activity. It wants to think about cancer in the context of other illness. And I think in Sheffield, you've been, in the north, you have been very much taking a lead in this sort of approach. And it's something that we're really going to have to take forward. So I wanted to, starting just by thinking about what have we achieved, and we will come on to this all the way through the day. How have things changed since we started the National Cancer Survivorship Initiative? Some of the challenges, data, different ways of working, and getting the interventions that we know work actually into practice. So just a brief mentions on the recovery package. We now know that that in the year following anti-cancer treatment, people have a very tough time. And if you don't get it right during that first year, then they tend to have long-term and persistent problems. So the importance of making sure that they are assessed properly during and at the end of treatment, that they have the information to help them get back into life, has become increasingly important. And I know that you accept it. You know this here. So the recovery package has been very important. But probably even more important is getting the culture change of getting people to work together differently. I think I showed this last year. I don't know, did anyone see this remember this one? So this is a picture from the National Portrait Gallery of Scotland. And it's a picture which is called The Oncologists. And they're real oncologists, and they really love this picture. But I think it is the old way of working, where cancer was the area where specialists dealt with it, and they were your barrier against the darkness. And the idea of people working together, where the patient in the middle can access specialist expertise when they need it, and generalist expertise for the other more general things when they need it, is a very different way of working. And that, I think, is the big challenge for taking things forward. So getting the recovery package in, so you recover after your anti-cancer treatment, but then moving to this different way of working where the patient is able to access all the different forms of expertise. And that is a huge culture change. And I think the importance of in terms of getting things going, of being able to have your tests organised, a proper assessment, and then getting back to the expertise that you require is probably going to need some form of navigation. And how that works will need to be tested in lots of different ways. But talking to generalists and specialists, working together in this way with the patient at the centre is a really tough challenge. So thinking about some of the things in relation to the recovery package and how they've worked well, we know that the assessment and the assessment process has its challenges, but we have been able to introduce that into a number of different settings and to produce a care plan. The challenge has been getting the care plan shared with the right people to enable action to be taken, and I know this will be discussed as we go along. If we look at the assessments, and I think Juliet will talk about this, we know that some of the key things that come up, fatigue, anxiety, sleep problems, pain, we know that these key symptoms come up time and time and time again. So we know what we need to be doing in terms to make sure that people have the things that they need. But we also know it's very important that people's care is planned. And in order to do that, we have to make sure that specialists give the right information to GPs and patients about the anti-cancer treatment that they've had and about the plan to go forward. And this, I think, has been a challenge to actually get right. And I think that will be one of the big challenges as we move forward. Not just assessment, not just a care plan, but making sure you have a proper treatment summary linked to the assessment and care plan, and making sure that these things are shared with the people who will actually be able to do something about what happens. Similarly, the health and well-being events, bringing all the different people who can help a patient, have been very successful in different parts of the country. But again, implementing it on a routine basis is our challenge for moving forward. I think one of the things that we've learned from the survivorship is the importance of changing the way nurse specialists work and share their skills, and changing the way that AHPs work and share their skills. And I just want to highlight this group, of which Diana Greenfield is a leading member, of nurse and AHP consultants who are active in research and in education, who've been really taking the lead of thinking about ways that can make a difference. And they've produced 10 top tips for cancer right through to a competency framework for nurses, which I think will be very important in moving forward, again, to implement the survivorship agenda. So, just from a summary point of view, I've just done a quick whistle-top tour, just perhaps a personal view of the things that have happened during the National Cancer Survivorship Initiative, some of the challenges that we have in terms of moving forward, many of which you are already addressing, and thinking about what we need to really focus on in terms of the future. I just wanted to just mention the Northern Ireland programme, because I think this was a very interesting population-based attempt where, they wanted to transform follow-up for a range of cancers, starting with breast cancer. That they did they've audited what the problems were in terms of their cancer, their population. They implemented the recovery package, starting off with bringing the assessment and care plan and the treatment summary record into the system. And bringing all the players together. And just to say now, at the end of the programme, they've now got over 50% of patients across the board in all the hospitals there being entered into supported self-management, starting with breast and now moving through prostate and colorectal cancer. And they've used their website, which I think is very well worth looking at in terms of taking things forward. But the key pieces of learning were you had to do the whole population. It takes time. Engaging people was one of the key processes. But that if you took everybody with you, the patient feedback was extremely positive, and actually it could be done. And I think looking at across a whole population, this is a very exciting way forward in terms of taking things there. And I know that today, many of the things that you've been doing here will also be taking that forward. So, whistle-stop tour, thank you very much.